So first, we just want to acknowledge Project Firstline. It's a national collaborative led by the U.S. Centers for Disease Control and Prevention to provide infection control training and education to frontline healthcare workers and public health personnel. AAP is proud to partner with Project Firstline as supported through a cooperative agreement. CDC is an agency within the Department of Health and Human Services, and the contents of this program do not necessarily represent the policies of AAP, CDC, or HHS and should not be considered an endorsement by the federal government. None of our presenters or planners had anything to disclose. And this is just our CME statement. A few quick reminders. I will be sending an evaluation after the webinar. You must complete the evaluation within 1 week to be eligible for CME credits. Even if you're not seeking CME, we would love if you filled out the evaluation. It just really helps inform our work going forward. All program attendees have been muted this morning, but if you have a question throughout the presentation, feel free to use the question box. You can also use the chat feature. I think Dr. Holmes might be making use of the chat feature a bit this morning, so please feel free. I know it's early, but we'd like to hear from you. And today's webinar is recorded and it will be sent out after the program to attendees. And now I'm so happy to introduce Dr. Melissa Holmes, Associate Chief Medical Informatics Officer and Assistant Professor in the Department of Pediatrics at Rush System for Health. Dr. Holmes, if you don't mind just introducing yourself briefly, and then I will let you take it from here.
Yeah, sure. Would you like me to switch to controlling the PowerPoint so I don't need you to advance, or what do you prefer?
It's totally up to you.
Then how about I share, and that way I don't have to keep asking you to advance, if that's okay.
Totally fine, yeah.
Okay, give me a minute, everyone. Are you able to see my slides?
Yes, that was very smooth.
Oh, thank you. Doesn't always go that way. Thanks everyone for being on this morning. As mentioned, my name is Melissa Holmes. I am clinically a practicing primary care pediatrician at Rush. I am also board certified in clinical informatics, and so I spend part of my time as an ACMIO at Rush. And was one of the group of ACMIOs under our CMIO who really got telehealth up and running during the pandemic. So we had a little bit of telehealth, but obviously, as we all experienced, there was a boom during the pandemic. So I have a lot to say on this topic. And if you were logged on early, you might hear that I'm actually doing telehealth as soon as we log off in a little bit. So as mentioned earlier, unfortunately, I have no relevant financial relationships to disclose, and I do not intend to discuss an unapproved or investigative use of a commercial product. So I have been asked today to present these slides that were really developed by Project Firstline, but as somebody who, has built a telehealth program and feels really strongly about telehealth, I've added some of my own thoughts in between as well. But our main objectives for today are to review the current AAP telehealth policy, to share best practices for telehealth utilization, and then to also obviously identify strategies to triage and eliminate the risk of transmission, which is kind of the whole point behind this Project Firstline presentation. So I wanted to start out by sharing this study. So it's Pediatricians' Experiences with Telehealth in 2021, which was published in Pediatrics. It is a study that looked at national weighted survey data collected from 3 cohorts of pediatricians participating in the AAP PLACES study. There were 635 pediatricians who were included, 340 of which were primary care, and 295 were subspecialists. And of this group, 63.4% had reported using telehealth for patient care in the past month, with the median number of visits being 10. So to make this somewhat interactive, I was hoping that you guys could go up to the top of your screen and send a thumbs up if you provide any care via telehealth. Got to find some way to make this interactive. So hopefully there's somebody out there that does telehealth, and hopefully you're not all commuting in this weather and can't do the thumbs up. No one? Okay. Well, we'll keep moving on. But like I said, this study really does show that majority of us pediatricians are utilizing telehealth, at least somewhat, in our practice. So the study also looked and it noted that the most common reasons that telehealth was being used was for chronic disease management, followed by sick visits, and then mental health visits, and then new patient visits. 60% of those that responded said that overall telehealth was working at least very well or moderately well in their work setting. And then I'm a little biased about this last one because I don't think that new patient visits work well for me. And I don't actually do new patient visits via telehealth, but subspecialists were more likely than primary care pediatricians to rate telehealth as very or moderately effective for new patient visits. And I think it just tends to make sense with our workflows. So in terms of primary care, pediatricians, the most common reasons that people are utilizing telehealth is for mental health, followed by chronic disease management, and then sick visits and new patients were actually much less. I will say I spend a lot of my Tuesday mornings doing a lot of ADHD, depression, anxiety, occasionally some developmental concerns, but this really fits with my practice. So taking another step back, let's talk about telehealth modalities, because I think when we think of telehealth, we tend to think of synchronous telehealth, where you're logged in and you can see the patient on the camera and you're talking back and forth. So that's synchronous, and then telephone is also synchronous as well, right? So even if you don't have that video component, it's still happening in real time. But then there's also asynchronous telehealth, and I bet you if you included this, many more people would say that they're participating in telehealth because that includes things such as secure portal messaging and file sharing. So now we wanted to talk a little bit about the AAP's telehealth policy. This is a view of one of the pages. That's the guidance on the necessary use of telehealth during the COVID-19 pandemic, when the AAP really came out with a statement in support of telehealth. You can still find that. I have links for those things at the bottom. And then there's also a policy statement from September of 2021 that's titled Telehealth, Improving Access to and Quality of Pediatric Healthcare. So in this policy, it said that the AAP strongly supported the continued provision of healthcare for children during the pandemic through the use of telehealth. So again, endorsing telehealth for use in pediatrics. That care should not be unnecessarily delayed, referrals should continue, that well child care should be provided consistent with Bright Future guidelines. So again, my biases will come in here, but as a primary care pediatrician, we kind of lost a lot of patients in those first 2 years of the pandemic, which, you know, we really should all be working to kind of, if the pandemic ever resurges like that, hopefully not, or when the next pandemic comes, because we know that's inevitable, we should really be utilizing telehealth to continue our regular well child care. And then they specifically say that well child care can be initiated through telehealth, but with the obvious caveat that some things need to happen in person, such as immunizations and labs. And I think you can get really creative as to how those things can be done. They made it a point to say that pediatric subspecialists and surgical subspecialists may conduct care via telehealth as well, and that all payers should pay for telehealth visits at parity, which was one of the biggest kind of things that happened with the pandemic, right? Is we actually did a very small amount of telehealth at Rush pre-pandemic, but a lot of that was not covered by insurance. And so now we have the option to kind of treat all of our patients, no matter their kind of income status, via telehealth. So now let's specifically talk about reducing the risk of transmission through telehealth. And I'm going to first talk about this in terms of the COVID-19 pandemic, but then I have some other really great examples as well. So obviously, one of the benefits of telehealth was the public health risk mitigation. So when we were all kind of shutting down to essential visits, making sure that we were maintaining distance, telehealth helped with that. Also reducing the strain on healthcare systems by minimizing patient surges. So our emergency department, like most emergency departments, were completely overwhelmed. We actually had access to the COVID-19 testing, I think, pretty early compared to what I've heard most of my colleagues say. And so people were having cold symptoms, right? And they were like, is my child developing COVID-19? Are they going to get severely ill? I'm going to have to rush to the emergency department, right? And so then our emergency department was filled, some with critically ill patients and some with patients that were just concerned because we were all trying to really determine what was happening during those initial stages of the pandemic. So one of the things that we did is we actually opened up kind of a on-demand telehealth program that in the beginning, although now it's expanded significantly, was just for COVID-19 concerns. So people could hop on and there was always somebody that was waiting. And we could, talk to the patient, talk to the family member, the parent, determine whether or not that child was critically ill and needed to go to the ER, which fortunately wasn't the case most of the time. Provide them with some guidance, reassurance that, a physician had looked at them. And then this was even before those drive-through swabs. We actually had people pull up in front of a building. Somebody would come out in full PPE, grab the patient from the car, bring them into the building and swab them and send them on their way. But again, that was a way to minimize both the surge and continue physical distancing. Obviously, reducing the use of PPE. So if we can all go back to that time that I think some of us have just completely shut out of our minds, there was a PPE shortage. We weren't able to get, some people were using N95s. And so we can reduce that by kind of keeping some people out of the system where we need to use PPE when it's not necessary. Again, screening and monitoring patients who have or might have COVID-19 and referring as appropriate. And then last but not least, providing access to essential healthcare for our non-COVID-19 patients. And that's kind of how we all just really, there was a huge push and all of a sudden we got telehealth kind of across the nation up and running. And I think it would have been a much slower process. And I often wonder, would we even have telehealth at the level we do today had we not had, the beginning of that pandemic? So I have two other examples apart from COVID-19 that I would like to share. So I was on call for my practice recently, and I had a mom call, and over the course of the conversation, it became obvious that this early school age child probably had chickenpox. So the child was unvaccinated, had a fever, had a rash, and turns out mom also said, and I have shingles. And so she was able to asynchronously share a photo. And then, I was able to call her back and kind of talk to her about this, what she needs to look out for and what she needs to do. Um, and of course, like, I think she felt guilty for probably not vaccinating her child. And then she read some of the more serious complications of varicella and was very concerned, although her child was very well. But we didn't want that child to come into our waiting room where we have a bunch of newborns waiting for their newborn visit who are at risk. And so this was a way to really provide that risk mitigation and make the parent feel comfortable and give the medical support that she needed. Another great example were siblings that had a cough, and these siblings had an immunosuppressed father who was undergoing oncologic treatment and had recently tested positive for tuberculosis. And so, with all of the stress this family was facing, the mother was convinced that her children now had tuberculosis. And so, do we really need to bring somebody with active TB into the office if they're not having any significant symptoms? And when you talk to this mom and you heard the story, it was actually a false positive TB. But had it not been, we didn't need to bring somebody with active TB that was stable into the office. We could have done some of that via telehealth. So those were two interesting examples. And not your typical, again, depression, anxiety, ADHD that I tend to do on my Tuesday mornings. So I'm going to ask, we'll see if anybody's interested in participating. I hate when I just talk to the screen, but I know that's part of these Zoom conversations. But I'm wondering if you guys would take a minute and in the chat, put in any other benefits of telehealth that you see. I'm going to give you guys a couple of seconds. I'm going to have a sip of coffee. We'll see if anyone feels like chatting, and we'll go from there. Okay. Well, I will keep talking. So some of the other benefits that we see of telehealth are improved patient monitoring. And so if you're starting a patient on a new medication, it's great for me when I start somebody on an SSRI, or even a stimulant, I can follow up with them very regularly, quickly, and titrate as needed. It's easier access to specialists. So if you have a pediatric patient that, for example, is in a rural area where there might not be a particular specialist, I don't know, a pediatric rheumatologist, they can have access to that specialist in a more remote location via telehealth. Improved access to care. I think a lot of times we don't think about this, but for me, it takes me, I think you could have to wait about 3 months perhaps to see me in person. We're just a very busy practice, but you can see me any Tuesday pretty much for telehealth. And so it opens up access. There's obviously the environmental benefits. Reducing practice overhead costs is another big piece. And so this really depends on the size of your practice, kind of the ownership model, how it's set up. But could there be a half day a week where everyone just does telehealth and follows up on their chronic disease management, mental health concerns? Because then you don't have to turn the lights on, you don't have to hire as many support staff, although that's not possible with certain kind of models. Reducing the need for time away from school and work. So some of my visits, I actually have a parent who's at work and a child who is at school, and the parent will, on their break, log on to a video visit, and the child will go down to the nurse's office or their guidance counselor's office, and we will do a video visit. And this allows them to not have absenteeism from work and school, which can be a really big deal. Again, improved continuity of care kind of goes along with that improved monitoring and access. Reducing hospital readmissions. This is a big one, and a lot of people have developed programming around this. But when you send somebody home, can you do a telehealth visit, make sure they've gotten their medications, that they're able to take their medications, and that their symptoms are improving? And if not, find a way to kind of encompass them back into in-person care rather than having them go back to the emergency department and get readmitted. Again, chronic disease management, because you have that close follow-up. It's not you have to wait, 3 months or 4 months. It's let's start you on these new asthma medications and let's check in a couple weeks and see how things are going. Increased family connection and support. So some people really rely on a support system that might not be close to home. And so this allows other people to join the visit and really help understand what's going on with the patient and provide support to all the family members. Clues from the home environment. So our pediatric dietitian actually does some telehealth, and she talks about really cool ways where when they're on the video, she says, go to your pantry, go to your cupboard, grab the cereal that you're eating for breakfast. Let's take a look at that together. Let's look at that label. Let's understand how to interpret it, and let's maybe find a better alternative. And you can't do that stuff in person. And then also convenience as a patient satisfier, right? We are in a fast-paced, technology-based society these days, and people like quick and convenient care, which telehealth can help provide. So speaking of telehealth pre and post pandemic, the big things that have changed are huge: policy, payment parity, and physician and patient acceptance. But unfortunately, the things that haven't changed are inequitable access, which we'll talk about a little bit more. There's obviously exam limitations. You can't be the same physician that you are over telehealth as you are in person. And then lack of personalization. I hear this a lot, I feel like, from some of my colleagues who take care of an older population where they're very used to seeing their doctor in person and having this particular rapport, and it just feels a little foreign to them to do a visit through telehealth. And so I do think it takes a particular personality of a physician or APP to provide telehealth where you can really develop that empathetic relationship through a video screen. So we'll talk a little bit about telehealth best practices. Again, there is a toolkit that the AAP has for telehealth. This is, again, kind of one of the landing pages that you can check out, but we'll share some of those things here now. So the biggest key is to determine the appropriateness of the telehealth visit. So consider your nurse triage options. If you have nurses that are doing triage, do they understand what your group is willing and not willing to do via telehealth? Scrub your schedule if you allow for self-scheduling. So people want care. And so sometimes they'll schedule themselves for a rash, but really they have other needs, and you have to be flexible and learn to pivot. But of course, if they're scheduling on your schedule via telehealth for immunizations, let's not waste anyone's time, and figure out a better way to make that happen. And then obviously clear communication to your patients on what are acceptable reasons for telehealth. And so here's a really good example. Healthychildren.org has some great information for families on telehealth and some great infographics, some of which I'll share here. But let patients know that you offer telehealth and what can be done via telehealth, and hopefully that will streamline things for your group. So here is one of those infographics, and it kind of explains that what's great for telehealth: rashes, pink eye, mental health, mild cold, and GI symptoms, what things should be done in person. Obviously, first newborn checkups, most regular checkups, especially if you need immunizations, labs, and other testing. So then you yourself need to be prepared for a telehealth visit. One of the first things is making sure that you're using a HIPAA compliant platform. So in the beginning of the pandemic, a lot of the HIPAA laws were made more lax to really support care that people needed. And I had heard of people doing visits on their iPhone via video calls, and maybe through Doximity dialer when they didn't have a BAA agreement. And all of that was just needed to get essential care to people. But now we're kind of beyond that. And so you really need to make sure that you are using a HIPAA compliant platform, making sure that you're on a private network in a private space, and then really determining if your patients need any accommodations prior to the visit. So I will say that this morning I have somebody on my schedule, and in the visit note, it says needs interpreter. But they didn't have an alternate language other than English listed. And so for us, and the way our system is built, is if you have any other language and you're scheduled for a telehealth, an interpreter is actually scheduled into that video visit as well. So the patient and their family, myself, and the interpreter all join at the same time. But I caught through scrubbing my own schedule that this patient needs an interpreter, but one hasn't been assigned because of the language criteria. So yesterday evening, I was messaging my office staff to say, can you kind of help me out with this so that when I'm done giving this talk, I can help that family. Preparing families, caregivers for telehealth visits. I always say you should create a tip sheet. And this tip sheet should be available broadly. It should be posted on your page's website, maybe posted in your office space, but then also re-provided when a visit is scheduled. It's great if you can kind of provide that automatically through the patient portal. Another great option is allowing test runs and giving tech support options. So allowing families to log on. We had some administrative folks who were non-clinical that were just helping families in the beginning when telehealth was very fresh. They could schedule a test visit, up to a week prior to their scheduled telehealth visit and just make sure they understood the process. Um, Made sure their camera and their mic worked and things like that. And I will say this is really important. And I experienced this with my own mother, and she allowed me to share this story here today. But she had logged on for a telehealth visit with her primary care doctor, and she saw herself on the screen. And so she assumed that she was in the video visit, but it was just like a preview screen of what her background was. And she needed to like hit one more thing to move forward. But she didn't see that because you had to scroll down on the page to advance. And so tech checks like that are super important. Asking caregivers to message the clinic with any videos or pictures prior to the appointment. So I don't know if you've ever done a telehealth visit on a 2-year-old with a rash, but as the parent is like got their iPhone and they're chasing the child around trying to look at the rash, it is not at all efficient. So we actually ask all like rash visits that they give still photos before they come on to the visit. Some people accept, some platforms accept videos as well. That's been super helpful when I've had patients with concerns, for example, abnormal movements. Is this an infantile spasm? And sending videos of what they're seeing can be really helpful. Another really great tip is to consider scheduling the visit when home nursing is there for your complex patients, or if a therapist is present, because one, they can provide additional information from their perspective, and also they can often help with the telehealth physical, which is great. So here is another infographic that's available on healthychildren.org. You could really take something like this and develop it for your own practice, as to how patients should prepare for a telehealth visit. For example, where it says get documents ready, there I would put complete your online questionnaires. I do a lot of Vanderbilt's, GAD-7s, PHQ-9s through telehealth, and I try to have those completed before I log on, so it's information I can use during the visit. Another thing that I think is really important that we don't often do is really making sure our families have access to a tele-ready device with a camera and mic and internet services. I don't think that we should take for granted that not all people have access to these devices and internet services. And so I posted links here to the No Device Barrier Buster and the No Signal Barrier Buster, but those are options to really help patients find accommodations when telehealth is needed and would work well for them. So here are some other examples from Family Voices on what you can do or what you can suggest. So as far as not having a phone or device, I think it's key to know that if a family is eligible for Medicaid, they can actually get a phone with monthly minutes and data from Lifeline. And then I think in terms of accessing devices, things that people should also consider along with getting internet access is, can they go to their public library and sit in one of those private rooms and do a visit? Do they have a faith-based organization that they're part of? Is their child's school able to help in any way? Consider family members, friends. I've told people, and I don't come across this often, but I think a good suggestion would be pull up outside of a Starbucks if you have a car, and use their free Wi-Fi. That's a way that if you don't have Wi-Fi on your device or at home, that you could make this work. But be sitting somewhere private where nobody has to hear that conversation, but you do then have access to internet services. So please feel free to check out these links later for Family Voices and the Lifeline program. And then lastly, follow-up planning is huge. You really need to consider the unique workflows of telehealth visits. I think we all take advantage of that back checkout process, as I like to call it. Stop at the back, they'll make your appointment, they'll hand you your referrals. But when you're doing telehealth, that doesn't happen. So how do you make this seamless? By obviously doing clear communication, which hopefully we're all practicing as much as possible, whether we're doing telehealth or in person. Making sure families know that they can review their notes and their instructions on the EHR portal. I don't think a lot of people know that. And so sometimes it's helpful. And I tell people, go back and read. We talked about a lot today. If you have any questions, send me a message. Communicate the plan for referrals, prescriptions, labs. And so I'm often providing them the number on the referral to make their appointment. I'm clarifying their pharmacy, which I don't often do in person. Um, telling them where and when they can get their labs done, when therapies might be scheduled, et cetera. And then if they need paperwork, how is that going to be achieved? I'm fortunate that I can provide paperwork through our portal and just send it directly to the patient or family in our portal. And then making sure that you're discussing the timing of the next appointment. How will that be scheduled? Are you going to schedule that? Do they need to call? Some people actually transfer, like they log off of the video visit and a clinical coordinator or an MA comes on and helps schedule that follow-up appointment. And then making it clear if that follow-up should be in person or if it can be done via telehealth. Another quick study that I wanted to share was telehealth usage among low-income racial and ethnic minority populations during the COVID-19 pandemic. So I think the first two things that I wanted to highlight are the main users of telehealth are females between the ages of 18 and 44. And that demographic fits a lot of mothers with children in my practice. And I know that families come in all different shapes and sizes, but I often have mothers that are accompanying their children to the visit. I, in my own household, am in charge of making the kids' appointments. And so telehealth is really something that fits our patients and their families. But moving beyond that, some of the other things that were noted is that the people that use telehealth commonly have completed a bachelor's degree, that income is more positively associated with telehealth in certain family sizes. And then among people whose incomes are below the federal poverty threshold, Hispanic and Asian patients were more likely to use telehealth than non-Hispanic, white, and Black patients. And I think that this just points out that the inequities that we know exist in the US healthcare system are pervasive into telemedicine. And so part of our job as pediatricians is to advocate to promote public health in our increasingly digital society. Let's not leave anyone behind. So how can you increase telehealth in your practice? I think the biggest thing is make it known to your patients. If you have social media pages, if you have websites, handouts, direct messaging through text and portal messages are super helpful. Ensuring easy and quick access. So that's one of the things that people love about telehealth. And so if it's like, you can have a telehealth appointment, but it's in 2 months, it's going to be like, no, forget it. So really developing a schedule that allows for that quick access. Making sure your providers are trained on usage and policies. Virtual care really requires clinicians who are flexible. I have to do a lot of tech support. There's sometimes screaming children in the background, and you just have to be flexible with families. You have to be able to easily demonstrate empathy. Again, sometimes that's more difficult to do through a screen than it is in person. And that goes along with having good communication skills. Making sure you train your staff too. Does your staff really understand what your telehealth program is? And maybe they can even help troubleshoot with patients. So our medical group had made the suggestion that we would do virtual rooming for our telehealth with our medical assistants. And this was great because it kind of fit the normal flow of an in-person visit where the MA would come on. For me, they would be putting in a chief complaint, they would be checking allergies, they would be putting in a pharmacy, but they were also doing throughout all of this, making sure the tech worked right. So that when I came on, the patient was just ready to go. And so that was super beneficial. Make sure you're innovative. There's really great ways that telehealth can be used if you just are kind of open to expanding options and thinking of ways to think out of the box. And then obviously making sure that you utilize the AAP Promoting Telehealth Campaign Toolkit, which is linked here. So To close, we know that telehealth is a beneficial tool for the care of families. We also know that it can be important in infection control. It's important to know that there are barriers to telehealth still, although we've overcome a lot of those. There are some that are still persistent and things that we need to advocate for. And that goes along with identifying and outreaching to families that are challenged by the use of telehealth and help bridge that gap. Consider both your synchronous and your asynchronous strategies to mitigate the risk of infectious disease transmission. And then be aware that there are resources for your use regarding telehealth at both the local, state, and national level. And so there's a lot of resources here on the next 2 slides that'll be shared with you all, but I just wanted to stop, pause, and ask if there were any questions. And thank you again for having me this morning.
Thank you for being here. And I apologize. It looks like I had the chat turned off. Someone asked for me to turn it on in the Q&A. So it's my fault you heard crickets.
Oh, I just thought people were commuting. No worries.
So if anybody has questions, feel free to pop them in the chat or use the Q&A. If not, we'll give you a few minutes here. But if not, thank you so much for your time this morning. Thank you, Dr. Holmes, for being here. As I said at the beginning, I know a few folks hopped on a little later, so I'll let you know again. We are sending out an evaluation after this. It's required if you are seeking CME. If you're not seeking CME, we still ask that you fill it out because it does help us inform our programming in the future. You'll also receive the webinar recording and a copy of the slides via email. So you can click on all those great links Dr. Holmes just shared.
So I see something in the chat. So it says, how do you feel about new patients undergoing telehealth for sick visits? And so we actually, and this is the way my practice is set up. So I can tell you the way my practice is set up and then my own kind of personal opinion. The way we work is that you have to have established care even before you come in for a sick visit. And I think part of that is because of the size of our practice. And so we don't do any telehealth for new sick visits. I think that it could be done, but it would have to be very controlled. And again, I think that's kind of about like scrubbing that schedule or having somebody do triage first, because I think you risk, potentially missing things that I, as a pediatrician, don't want to miss. And so I'm more willing probably than some of my colleagues, but I think that, you need to kind of tell patients, I'd love for you to come back in person at some point. I can only get to know you so well through this video visit. It appears, that overall, I think you're, safe to stay at home and do these things. But again, if X, Y, or Z happens, then you need to come in person. You need to call our office and kind of just documenting that. But if we don't do it, people are going to do it, right? I'd rather me as the pediatrician do it than a non-pediatrician that does it through some other telehealth means. And so I think that's where we kind of need to step outside of our comfort zone. I hope that was helpful.
Thank you. And thanks for the question. Just a couple more minutes here. I'm always bad at the waiting.
Me as well, but I'm going to have another sip of coffee and be recorded having a sip of coffee. So I apologize.
Well, I suppose we'll give everyone 15 minutes back. Oh, just kidding.
Group visits. Yeah. So again, in my practice, I don't do any group visits, but our psychology team, for example, and our psychiatry team does do group visits. I haven't actually taken part in one of those, but we have a platform that allows multiple people to come on. Obviously, the family has consented to the fact that it's a group visit. I think a lot of those people have done group therapy, for example, in the past, and so they're kind of experienced with it. I think you just need to explain what a group visit is going to consist of. Again, having them consent in some way to it, but I think it seems to work great for some of those mental health kind of concerns, and our psychologists and psychiatrists use it regularly. And if we're talking about like is it legally? I don't think there's any specific requirement that you have to have a one-on-one, but I would say I don't think many people do group visits before a patient is established, but I don't think there's any kind of policy on that that I'm aware of. I would need to look that up to be certain because I am not a legal and compliance expert. Although people often in my organization think that I am, just by nature of my role. Uh, but I don't think there's any policy, but I would say that I feel like a lot of people probably have some interaction with those folks before they get into a group visit. It'd be great to do like a group visit, like just for like almost like essential, again, thinking of my clinical role, like for newborns, right? Like parents often, first-time parents have tons of questions that arise. So could you, with your established newborns, do some sort of group visit where it's parents supporting each other, but then asking questions and parents learning from other parents' questions? I think that that would be fabulous. I just have to find somebody to let me do it.
Well, again, thanks everyone for being here. Thanks for the great questions this morning. Thank you so much, Dr. Holmes, for your time. It's always a pleasure. And I will be in touch with everything I told you I would send you. So have a great day, everyone, and thanks again.
Take care. Thank you.